Yeah. So I think Pooja is the student presenting no, today. Hello, Deepti, are you there?
Yes, ma'am.
Yeah, all those who are there, just put your audio at least on or video, both if possible. Dr. Sunil, you are there?
Yeah, I'm very much there.
Yeah, so you had a prior discussion with Dr. Varsha and Dr. Bhojani, no?
Yes, we had a discussion yesterday. Good morning.
Good morning, yeah. So the student is just trying to log in, Dr. Pooja. I told her. So as we discussed last time, the questions will be directed to the candidate, Dr. Pooja, but others also have to answer, huh? Deepti and Yash first, and then the others. Huh? Don't just log in and... Yeah. I think it's almost 11, no?
Yeah, about 3 minutes. So
Okay. You can start off the case presentation and I'll introduce Dr. Avinash when they are winding up. So I think you all have decided, no, the sequence and all.
between us?
Yeah, between three of you.
Yeah.
Yeah. I mean, like try to wind it up in 55 minutes, so that it doesn't get prolonged too much. Otherwise, the talk will go on longer. Than we have time, but I think latest by 12:45 we should wind it up. Yeah.
And the
we'll
next try.
And another thing is next class will not be on 19th March because most of the people are going for the WRF Jaipur.
Correct.
Yeah. So we're planning on 26th. Deepti, you're presenting next time, huh?
Yes, ma'am. Okay, ma'am.
So we are trying for 26th, but the guest speaker is Dr. Danda that day. So I'll have to just confirm with him.
Okay.
Because they are busy people, no? So I'll let you know. Okay.
Sure, ma'am.
So it will not be 19th March. It will be either 26th or I'll let you know the date if there's a change.
Okay.
Yeah. Okay. Soham has joined. So we have some new students here. Dr. Vallabh, you can introduce yourself. Mute. You are muted. Unmute yourself. Yeah.
Hi, I'm Dr. Vallabh Manatkar. I have done MD Medicine from Krishna Hospital, Karad, and I have joined as a fellow at CRD, Pune.
He's joined Dr. Chopra. So Dr. Chopra had been, yeah. And Dr. Soham, you can introduce yourself. Okay, Akanksha, you're there. You can introduce yourself till then.
Good morning, ma'am. Good morning to all the teachers and my colleagues. I'm Dr. Akanksha. I have recently joined DM program at Bharti Vidyapeeth.
Yeah, she's our first year student. And yes, Deepti, you can reintroduce yourself.
Good morning, everybody. I'm Dr. Deepti. I'm a DM resident second year at Bharti Vidyapeeth, Pune.
Okay, Dr. Yash. Okay, Dr. Yash, Dr. Soham.
Good morning. Good morning, everyone. I am Dr. Yash Desai. I'm from Mumbai. I am a rheumatology fellow in DY Patil Hospital, Nerul.
Nerul.
Yes.
Okay. Yeah, good. Welcome. Dr. Aditi and Dr. Aarti. You can introduce yourselves, unmute and introduce. Yeah.
Good morning, ma'am. So I'm Dr. Aditi. I'm from PD Hinduja Hospital. I'm a DRNP trainee, second year right now.
Good morning, everyone. I'm Dr. Aarti Zope. I'm a rheumatology fellow at Sion Hospital.
Okay, so the student is having some issue with the Zoom, but I think all of you were able to log in easily, no?
Yes,
no issue.
Yeah, ma'am.
Yeah.
Yes, ma'am.
Yes.
Yeah, I don't know. Anybody is from Hinduja or from the Aarti and Aditi, which institutions?
Aditi is from Hinduja. Aditi, can you check what is the issue?
Yes, ma'am. I'll check with Dr. Girisha. I'll check with her.
Yeah. Okay. And Aarti is from which institution?
Sion Hospital.
Sion Hospital. So you presented the first time, no?
Yes, ma'am. Yes, ma'am.
Yes, yeah. Okay. So all of you, please be free to answer. And the guest lectures are for you all only. So this time we have a good topic on qualitative research, which is something which most of us don't do. So you should, if you have queries, you must answer. Dr. Avinash is one of the few people who's doing qualitative research and lots of studies with ICMR. Okay, then there is Sirala Bhupati. Yeah. Dr. Varsha has joined, yeah. Yeah, Rutuja, that's Dr. Rutuja. Yeah, Varsha has joined, yeah.
Good morning.
Hi, Varsha.
Hi, good morning.
Yeah.
Hi, Dr. Sunil.
Good morning, Dr. Varsha.
Good morning. How are you?
Good.
We could have a meeting yesterday, Kavita ma'am. So
You had, no?
yeah.
Okay. Yeah, so we are just waiting for the student to log in, and Dr. Bhojani also hasn't joined in yet, yeah. Dr. Shyam, you can introduce yourself.
Hello, everyone. This is Dr. Shyam. I'm a senior resident in Bharti Vidyapeeth. I just joined 1 month back. I'm the first year resident.
Okay. Then Dr. Bishakha, Dr. Kaushik has joined, yeah. Hi, Dr. Kaushik, good morning. You're muted. You're muted, yeah.
Kaushik is coming in 2 minutes. This is Neil.
Fine. Even a student has yet to arrive. She's having
So student has not joined.
Yeah, she's not able to log in, actually. That's what I was telling. All of us have logged in very easily today. So she's having some Zoom issues. Yeah. We'll have to wait till she comes, otherwise we can't start. Yeah. And Dr. Varsha, I told the others, 19th March session will not be on 19th. It will, because we'll be at Jaipur, no? So it will be like mostly 6th March. So I'll clarify the dates soon. Yeah.
Just 2 minutes, sir. She has now been able to log in, it seems.
You're along with her in the same campus or what? Or you're at different locations right now? There's a technical person from MRA also here.
I think she is joined.
She's
there is
joined.
one logo
Girijala?
saying MRA, but
She's joined. Yeah.
Good morning, ma'am. Good morning, sir. Good morning, everyone.
Yeah, you can just try to share your first slide.
Yes, ma'am. I'm just.
I just see if everybody can see. Then when Dr. Bhojani joins, you can start. Hi, Dr. Avinash.
Yeah, hello, ma'am. How are you?
Hi, I'm good. How are you?
I'm also good.
Good morning.
Yeah.
Good morning, everyone.
Good morning.
My name is
Good
Kaushik.
morning.
I'm sorry I'm 5 minutes late.
No problem. So the student is also there.
Good
and all the
morning, sir.
faculty are there.
Good
So
morning.
Dr.
Good morning, madam.
Hi.
Dr. Kaushik, Dr. Varsha, and Dr. Sunil will start off with the case presentation. And the student is Dr. Girija Sajdev. If she can't answer, then the first few questions will go to Dr. Yash and Dr. Deepti. and then anybody else can also be answered. Please do not stay silent. And after this, we have a very interesting guest lecture by Dr. Avinash Jain. Okay. So, Dr. Sunil, Dr. Bhojani, Dr. Varsha, you can take over. Huh?
Yes. Okay, so, can you start the presentation, Dr. Girija? You have a PPT? Can you hear me?
Yes, ma'am, I can hear you. I'm just trying to share the screen, but I'm not actually getting it.
I mean, is there any technical glitch, Girija? What
Yes,
is the
no,
issue?
sir, actually, I am selecting on share screen, and then I'm not able. Chrome tab, Zoom, Chrome, share. It's not seen.
So you'll have to share it.
Yes,
There is
ma'am.
a share
My
screen
present.
option. Yeah, so
Yes,
you've
ma'am.
clicked on it now. So your presentation is somewhere on your desktop.
Yes, yes, ma'am.
Yeah, so could you access it now?
Ma'am, I'm shared it. I don't know why is it not being seen. Chrome tab, share audio, select entire screen.
So you only share the PPT. No. Yeah, just the PPT. Yeah.
Perfect.
Is it seen, ma'am?
Great. Yes. Now
Yes,
it's
yes.
seen.
Go ahead.
But I am not able to. I'm not seeing anybody else. I don't know how. Okay.
No, we can see it. Yeah.
Good morning. Good morning, all the teachers. I'll be presenting case today. Myself, Dr. Girija, a fellow at Hinduja Hospital. Shall I start, ma'am?
Yes.
Yes, please.
So 48-year-old male from Andheri who had a desk job presented to the OPD with chief complaints of erythematous patches on the scalp since 2 years, nail disfigurement since 1.5 years, and low back pain since 1 year, and multiple joint pain and swelling since 4 months. So patient was apparently all right 2 years back when he started complaining of patches of erythematous, scaly and mildly itchy scalp lesions with powder-like scales from the lesions on scratching, which exaggerated during winters, and initially treated as dandruff and responded partially and transiently to topical medications and not associated with increased hair fall. 6 months later, patient started noticing yellowish discoloration along with progressive disfigurement of nails of left middle and ring finger with similar lesions on the right ring finger, not associated with history of trauma. So, since a year, he started complaining of low back pain, which was mainly the right buttock area radiating to mid-thigh posteriorly, more in the morning immediately after getting up. This was associated with stiffness in the morning, lasting for 1.5 to 2 hours, associated with difficulty in getting out of bed, usually improves with day-to-day activities and aggravated by inactivity. Symptoms were relapsing, remitting in nature initially and have become persistent in nature since last 4 months. Pain reduces in intensity but is, however, persistent throughout the day. Now, since past 4 months, patient also complains of pain and swelling of small joints of hand, mainly involving the right index finger, right hand index finger, PIP, DIP, and the PIP of the ring finger. Similarly, on the left hand, he had pain and swelling of the left hand index finger, PIP. And this was associated with morning stiffness of more than 30 minutes. The involvement of peripheral joints was had an additive pattern with bilateral knee in pain and swelling, which got involved a month later. He had right knee pain and swelling more than the left. Pain more in the morning associated with stiffness lasting for 30 minutes to an hour, and it relieved partially with some unnamed medicines. So for the above symptoms, initially patient used to take some unnamed medicines from the local doctor 2 to 3 times a month, with which he used to get 60 to 70% relief in the back pain. Now, since 4 months, for increase in his symptoms, he takes tablet aceclofenac or diclofenac 3 to 4 times a week. But more
Dr.
so since
Girija, may I interrupt? Dr. Girija,
yes, sir,
may I
yes,
interrupt for a minute?
yes, sir.
60 to 70% relief in the back pain, and how much was the relief in the peripheral arthritis?
So sir, now actually this was the initially when he had a few like just the back pain he had. So this was when it was relapsing remitting nature, this was initial part. So now in peripheral symptoms, sir, he didn't have any relief. So that is why since 4 months since a week he's taking diclofenac continuously, and even 3 to 4 times a week prior to that. So this was the when he had back pain intermittent in nature, sir.
Okay, all right.
Also, he had a history that he had consulted an orthopedician a month ago and was prescribed a weekly medicine. But however, he took it for 2 to 3 weeks, and with but he didn't have any relief, so he stopped. So now he finds difficulty to get out of the bed in the morning, difficulty in walking immediately after getting up. He can open the doorknob, he can take bath with some difficulty. He can dress and undress himself. Back stiffens with prolonged sitting. Pain in the right knee increases after a period of inactivity and also while walking.
Girija?
Yes, ma'am.
So can you just go to your first symptom slide?
Yes, ma'am.
Yeah. So the slow back pain that he had, that is since 1 year.
Yes, ma'am.
Right? And
yes,
the joint pains occurred after the low back pain, right?
Yes, ma'am.
You have described the back pain?
Yes, ma'am.
Yeah, can you describe it for us?
Yes, ma'am. So, ma'am, this back pain, what he had was, he complained of low back pain mostly towards a right buttock region and radiating to mid thigh. This back pain, it was because of the back pain, he find pain while getting up. It was associated with stiffness in the morning for 1.5 to 2 hours. Also, he found difficult to get up immediately from supine position, and also in turning side to side in his bed. And after with activity, the pain used to the stiffness used to relieve to some point.
Okay.
So what kind of pain this is, Girija? What are you trying to tell us through this history?
With the typical history, sir, yes, sir. So with
of the back pain, I mean, yeah.
Yes, yes, sir, yes, sir. So with the typical history that the patient gives of this is kind of insidious low onset and mainly with the morning stiffness. So this looks like an inflammatory back pain because it there's stiffness, the pain increases with inactivity and also gets relieved with some activity. And this is more in the morning immediately after getting up, sir. And also he finds difficulty in turning in bed. So this is the typical kind of history for which the patient, for an inflammatory back pain that the patient gives.
Can this be a disc disease with radicular pain, which is going into the thigh?
Yes, sir, it can be, but more of the, it cannot be because in this disease, pain will be more with activity, more with bending forward, and typical early morning stiffness should not be the way that patient should be describing in case of prolapsed disc. And radiating can be till thigh, can be till even below the thigh because of the compression of the nerves.
Yeah. So what is the character of that kind of pain? That radiating pain you get in disc disease?
Yes, sir. Yes, ma'am. Sorry.
So how is that pain?
That is more of kind of radiating sharp and more with activity like bending forward, or patient will also be having history of either obesity or lifting heavy weight, which would have aggravated the pain.
Yeah, that may or may not be there, but there are
Yes,
some
ma'am.
few more characteristics to that kind of pain, because see, he's 48, right?
Yes, ma'am.
And he's been sitting on a desk.
Yes.
And so
Sharp.
so can you tell us
Shooting
something
kind
more?
of
Yeah.
sharp.
So sharp shooting or lancinating
Yeah,
pain,
yes, ma'am.
radiating towards some dermatomes. You know, it has to be neurospecific, no?
Yes.
It's a neuralgic kind
Yes.
of pain.
Yes, ma'am.
Increasing on
Activity.
coughing, sneezing, straining.
Sneezing.
Remember your
Yes.
old medicine clinics. Yeah.
Yes.
Dr. Girija, can I ask a question?
Yes, sir.
It's a unilateral low back pain.
Yes, sir.
I understand that it started with skin lesions first, and thereafter you realized on the history that the patient also had low back pain. But you're very specific about the fact that it's right-sided low back pain radiating to the lower limb.
Yes, sir.
Could you elaborate a little bit on other differentials of a unilateral low back pain that you would like to rule out on history?
Yes, sir. So unilateral low back pain, sir, it could be up because this is chronic. Other DDs could be, sir, if patient has typical distribution in like dysesthesia kind of in anterolateral aspect of the thigh, it could be due to compression of the lateral cutaneous nerve of the thigh, like meralgia paresthetica, but that will be more of in the anterolateral distribution, not just the but like low back and buttock.
That won't be back pain.
Yes, yes, ma'am.
Paresthetica will have thigh pain, but it
Yeah.
won't low back pain coming down. So that really doesn't count.
Yes, sir. There can be like greater trochanteric pain syndrome, the region. If there is a trochanteric bursitis, then it will be localized pain at the near in the region of the trochanteric bursa.
Beta, give me differentials of low back pain. You're giving me differentials of right lower limb issues, not necessarily of pain. But what I would kind of encourage you to start thinking, how would you rule out, other causes of unilateral leg pain? So you did mention about the fact that Madam asked about your PIVD, and you gave a very good description of what you would expect as far as PIVD is concerned. Excellent description. But the fact remains that there are many other syndromes which are also going to give unilateral low back pain apart from PIVD, but make sure that the causes that you talk about are those which come from the low back, not in the anterior region of the thigh, not the greater trochanteric. So there are lots of other non-inflammatory lesions which would behave like this. So what in your history, when you start with in terms of low back pain, it would make a reasonable argument for you to be able to say that there was a lot of difficulty in turning sides in bed and the rest of what you have already spoken. But even then, as a rheumatologist in the making, what is it that you would consider for a unilateral back pain coming down to the thigh? And so you must want to rule out other things.
Yes,
and,
sir.
I'm just waiting for you before I encourage you with answers, because I'd like to stimulate your thinking. The idea is to get you to expand your differentials, not for us to give you a didactic lecture.
Yes, sir. So, low back pain, just not inflammatory, keeping in mind the other non-inflammatory causes, sir. It could be depending again on the onset, like acute or chronic. So acute onset, sudden onset low back pain, like the prolapse intervertebral disc. If the patient typically complains of pain while walking, kind of claudication, like if patient starts walking for some time and he cannot walk after a distance, so it could be lumbar canal stenosis, or if it is associated and chronic other in cases of um, other metabolic, apart from rheumatological, other metabolic, if the patient has fever, indolent, but not typically, if we with neurological symptoms, if the patient is having like uh, stiffness while walking, tightness, but if tuber keeping in mind if TB is fine, but this is not the usual.
Yes, yes.
Usual
That's all
area.
we were asking you to speak
Yes.
on. That's
Yes.
all we were asking, that you must rule out in a unilateral sacroiliac,
Yes.
so-called sacroiliac luteal region radiating down. That's what you're hinting is sacroiliac involvement. And
Yes,
so
sir.
one thing that you must keep in mind is a unilateral sacroiliitis rule out infection. And an
Yes, sir.
indolent infection is important. So can you go in that direction a little bit more, please?
Sorry, sir.
So go down that train of thought and tell us some other thoughts that you get for the unilateral pain.
The most important first, after ruling out infection or local traumatic, could be traumatic, sir. And
also what?
The other two residents can also chip in. Dipti or Yash, if
Yes,
you know the
yes.
answers, feel free to just come in and answer before Dr. Kaushik gives you the answer himself.
It could be.
So I would.
Yes, Girija, you can answer this.
Yes, ma'am. I'll try.
Yes.
Keeping in mind, actually, the patient is 48, but had it been an elderly, there could be metastasis, malignancy, mainly to rule out. Metabolic bone diseases, Paget's, or like something Paget's patient can present with bone pain, but then that case, not necessarily, it could be a radiating kind of pain. So acute, in acute causes like prolapse intervertebral disc, chronic, indolent, most commonly unilateral, to rule out tuberculosis of TB, tuberculosis of sacroiliac joint, or metabolic causes, Paget's disease, or malignancy, or elderly, it could be multiple myeloma, mainly malignancy, and all these things I would like to
Very
keep
nice,
in mind.
very nice, very nice. But I'd like to encourage you to divide your thought process into two kinds: inflammatory, non-inflammatory, and the infective causes. If you train your thought to answer that way, it's your thought process that we are trying to encourage out here. And the idea is to expand your differentials. So if you are talking about inflammatory causes and you are stuck on the erythematous patches on the scalp, which is why you're not thinking beyond. But you must remember that the erythematous patches on the scalp can be even due to other causes and not just what you're trying to hint out here. We'll discuss that as you go along in the history. But otherwise, when you talk about unilateral, and this question has been asked, you might want to consider, apart from spondyloarthropathy, you want to consider all the types of spondyloarthropathy. So Reiter syndrome, for example, in a male patient. Or for that matter, you might want to go ahead and think about brucellosis in your infective causes, because these are indolent infections. The indolent ones are the mycobacterial ones, the fastidious organisms, so to speak. Your history is very clear about the fact that there are no systemic fever like B symptoms available in this patient. So when asked a question, even if not asked a question, when you're addressing the patient on the bedside, the way your mind should work is, one, inflammatory. Because you're a rheumatologist, you would be biased towards starting with inflammatory causes and either negating them or encouraging them. That depends on what you get in the history. Then you would talk about your metabolic causes, because once again, there are no real B symptoms to talk about. And then The third thing that you would later come to is the fact that, am I missing an indolent infection here? And am I
Yes.
going to be taken for a ride here? And is this a disease in evolution where the fever has not yet come in? So for example, currently I have a patient under me who is a case of brucella endocarditis, and she had back pain and a lot of other symptoms of musculoskeletal origin without any fever. The fever has come in after 3-4 months. And
Yes.
she had some skin lesions which were passed off as query viral, query whatever, whereas those were the splinter hemorrhages and the Janway lesions. So you have spoken about the nail disfigurement in the chief complaints, and we'll listen to your chief. But this is how I'd like you to think, and I'll stop here because otherwise your history will not continue.
Yes, sir. Yes.
Sure. Just on the same point, Girija, are you aware of what we call as the red flag signs about all that we discussed? So quickly, can you enumerate 1, 2, 3, 4 the red flag signs in a case of low back pain that you either
Yes,
ask
sir.
for or you look for? Yeah.
Yes, sir. Neurological symptoms, patient difficulty in walking, stiffness, or involvement of bladder and bowel.
Okay.
Sudden or acute onset is a red flag sign.
What else? What else? Yeah, same line of thought.
Weight.
Yes, yes.
Weight
Yes, you're
loss,
right. Go ahead. Yes.
weight loss.
Yes, yes.
And the same B symptoms mainly to rule out if we are not missing out on other treatable cause and not just rheumatological cause. Like most will be flaring
Yeah,
up infection. So again,
Fair enough, Girija. The only thing
Yes.
is that if the question is very specific, you just elaborate 1, 2, 3, 4, and that's it. I mean, we know that the the inflammatory and the metabolic. So the red flag signs are whatever you said: neurological involvement, the B symptoms, the fever, the weight loss, and the history of trauma, acute injury. So that's it. So I think we
Yes.
have dwelled on the back pain part, and I think we'll allow you to move forward now because we have to respect time also. So go ahead. I think Dr. Kaushik was asking about the scalp and the nail part of it.
Yes, sir.
Yeah.
Okay, can I start, sir?
Yeah, sure. Proceed.
So on a patient, there was no history suggestive of any other articular or extra-articular features, no history of fever prior to the onset or any infection prior to the onset of these symptoms, no history of weight loss, no history of diabetes, hypertension, cardiovascular illness, or tuberculosis in the past.
So
Patient
Girija,
had a,
just may I
yes,
interrupt here? What extra-articular features history you've asked?
yes, ma'am. So now keeping in mind the typical kind of the inflammatory symptoms with the scalp lesions, with the nail changes, ma'am, I would like to, the other extra-articular features that I would like to ask to the patient would be did the patient have any redness in his eyes? Or ever did the patient have an altered bowel symptoms, frequent loose stools or blood in stools? Or if the patient had swelling behind heel pain or swelling behind the heel, any
That's not
family.
extra-articular, beta. That's not extra-articular.
That is, yeah, that's musculoskeletal.
Yeah. And keeping in mind the typical kind of psoriatic kind of lesions, I would also systemic features like excessive weight gain, diabetes, hypertension, prior history of any patient had altered bowel habits, typically to rule out, ma'am, inflammatory bowel disease or uveitis, psoriasis in the family, anybody having psoriasis in the family, or back pain in the family, prior history of any gastrointestinal or genitourinary tract infection
So
prior to the onset.
Dr. Girija, your extra-articular features, you spoke about the scalp lesions, you spoke about erythematous scalp lesions, you spoke about powdery, you spoke about mildly itchy,
Yes, sir.
worsening in the winter. I heard all that. and I have taken cognizance. The question is, there was no description of the nails, number one. Nails could well be just fungal infection. The
Yes.
scalp lesion could well be just eczematous lesions. And so could you, when you are like, since you mentioned the word psoriasis and you went ahead and spoke about the other things right now, just right now for Dr. Bhatt, you spoke about the fact that, there are no other extra manifestations to suggest psoriasis. So you have already gone to the fact that this is psoriasis, right? Whereas what we heard is progressive disfigurement of the nails of the left, middle, and ring finger. Now, I would, I would ask you to talk about what other description here. So was there ridging? Was there a dirty nail sign? Was there nail pittings? Were there surrounding the cuticular margins of the nails? So what I'm trying to hint at out here is you want to prove that this is a psoriatic nail and not a fungal infection,
Yes.
right?
Yes.
So I just thought
Yes.
I'd bring that to your notice. Please carry on.
Yes. Yes, sir.
Girija, I think you can proceed. If your history is done, then we will see what you have in your findings.
Yes.
Yeah.
Yes. So there was no history of any comorbidities in the past. There was no history of psoriasis in the family, psoriatic arthritis, inflammatory back pain in the family, no history of allergies. And about the treatment, he was on tablet diclofenac since a week, and however, he did not continue any weekly medicines as he was prescribed. So summarizing, 48-year-old male, symptomatic since 2 years, with scalp lesions, nail changes, inflammatory type of back pain, with polyarticular pain without enthesitis or dactylitis or other extra-articular features, is most likely a case of psoriatic arthritis with axial, peripheral, scalp, and nail involvement. I would still like to confirm with further examination.
Excellent. Your own teacher, in fact, spearheaded a multi-center study of psoriatic arthritis very, very recently. And I think your senior just has possibly closed the data and done whatever. So the
Yes.
polyarticular joint pains in your differential being psoriatic arthritis, would you like to kind of tell us what kind of psoriatic arthritis you're looking at? How many types do you know? And what kind of psoriatic arthritis? Was this asymmetric polyarticular joint pain? Was this whatever? Yeah.
Yes, sir. So based on the traditional, as we know, Wright and Moll classified the psoriatic arthritis into 5 main types. DIP involvement, however, that is very just the DIP involvement is less than 5%. It could be like involvement like RA, symmetric poly, or it can be asymmetric poly arthritis, spine involvement, and arthritis mutilans. So these are the typical involvement of which, however, how they describe is not necessarily the patient can just fit into one. And usually there is an overlap of the patterns that the patient can fit in. So here with here this patient has back also, and along with that he has asymmetry. Actually he has small joints of both the hands, but not the typical that of like RA, but it is kind of overlap with the back involvement and with the peripheral joints
You
involvement.
spoke about the PIP, the DIP. I recognize that. I'm sorry if I missed the dactylitis part of it. Did I hear a sausage finger anywhere, Sunil? Did I miss it?
No, I don't think
The
that is
patient didn't have such history, sir.
But you've written here dactylitis.
No,
Yes, sir,
she's
with that.
without.
dactylitis. So did he
No,
have
It's written, Sunil.
yeah.
With polyarticular joint pains
Without.
without enthesitis.
Without enthesitis
Without.
I
dactylitis.
apologize.
Yeah.
I apologize. My bad.
No issue. I think we'll take up the examination findings. Yeah. Yeah. Go ahead.
On general examination, the patient was comfortable with stable vitals, weight 66 and body mass index of 26.8. This becomes again important, keeping in mind association with metabolic syndrome. On general examination, the skin examination, mainly it was the scalp. So this was the lesion that we can see. He had crossing the hairline. This was the largest one. He had few patches around in the scalp, and largest one measuring 7 by 5 centimeters probably, without skin involvement anywhere. PASI was very low. Tried to calculate it, so ma'am.
Which kind of psoriasis is this?
Plaque psoriasis.
How many types of
Scalp
psoriasis?
psoriasis. Yes, sir. So psoriasis can be plaque psoriasis or guttate psoriasis, or very severe form erythrodermic psoriasis or inverse psoriasis, typically in the mammillary folds below the this or groin region, flexural aspects in the creases, that is the inverse psoriasis, palmoplantar psoriasis, pustulo psoriasis.
Excellent.
Okay. Yeah.
Excellent. So, what is the maximum association of a particular psoriasis with an arthritis? Which kind of psoriasis is usually associated commonly with an arthritis in order of?
So mostly very strong association that they say is of the nail psoriasis. Whenever there is nail involvement, more chances of the patient going into arthritis with nail pitting, disfigurement, and typically of the DIP. However, patient can have other articular symptoms also. Then scalp psoriasis, or and in general, psoriasis has a chance of going into 3 to 30% of the patient of psoriasis can go into psoriatic arthritis.
So
Overall,
how much percentage of psoriatic arthritis can come before psoriasis? I mean, psoriasis lesions are not there, but only the PSA is there.
Yes, 10 to 15%. So it goes, ma'am, 75 to 85% of the patients have preceding psoriasis and then arthritis. 10 to 15% have arthritis prior and then skin psoriasis. However, again, 10 to 15% have both the things simultaneously.
Excellent.
Okay, Girija, you mentioned eyes, no redness. And I'll just direct this question to maybe Deepti and ask her that if there was redness of eyes in this case, what would be considering? And then in general, go on to the second part and maybe answer that in general an eye examination in a rheumat case. What are you looking for? Very quickly, just the enumerating part without lot of description. So redness of eyes first in this case.
Redness of, yes, sir. In this case, I would be really careful about uveitis. Mostly,
Girija, sorry.
Yes.
Sorry, just was I just wanted the other.
Yeah, the other two students.
So there are two more students who we just want a couple of questions directed toward them. So if Deepti is there, or Deepti, if I'm not mistaken, or Dr. Yash, one of them can take this question.
Presence of redness can indicate, depending on the type, that it can be uveitis A. Then there can also be, in this particular case, we are more interested in uveitis. And per se, in other rheumatological issues, we can look at scleritis or conjunctivitis if there is any. And
no, keep naming the illnesses parallelly, because otherwise it's just an ocular description. Yeah.
Okay. If scleritis, if you're looking at in relation with the spondyloarthritis, it is less likely, sir. It can be more with RA or vasculitis, what we are thinking. And if there is any redness or sicca symptoms, then we can think of the CTDs like Sjogren's and lupus, and also RA associated sicca symptoms. And with respect to SPA, mostly we are looking at uveitis, sir.
Okay. Conjunctivitis?
Any other cause of uveitis apart from SPA?
Sarcoidosis, Behçet.
Yeah, sarcoidosis. So you have to keep your vista open.
Scleritis more of can go in favor of RA or vasculitis, ANCA vasculitis.
Yes.
Okay. And Dr. Yash, if this patient had some reddish lesions over the legs which were painful, what would you think of, and how do it change your differential in this particular case itself?
So reddish lesions over the legs in a male patient, it could also direct us towards erythema nodosum.
Okay, and so in this context of this case, anything that additionally you'll start thinking, given the low back pain and the asymmetrical joint involvement? Of course, the knee was symmetrical here, but the other hand joint. So yeah, what would you think?
Sir, also sarcoidosis.
Okay.
Any other causes of erythema nodosum?
TB.
Yes.
Tuberculosis
Yes.
can also have some painful lesion.
What else? So arthritis also may be there. Some neuritis also may be there. EN is there.
Besets.
Behçet.
No, infective. Something infection again.
Tuberculosis.
Yes.
And can Hansen's leprosy
Yes,
also cause erythema nodosum?
Yes.
Yeah, so if this patient with an inflammatory back pain and this kind of thing comes to you with erythema nodosum, GI symptoms need to be looked at carefully, and a possibility of an IBD also has to be kept in mind, apart from all the other differentials, and definitely tuberculosis, keeping in mind that we have been discussing about that. So yeah, go ahead with your other examination findings.
So general examination, there was skin and nail involvement. The nails had your, as we can see, they're both hands, but this is the left hand, ring and middle finger, showing icolysis, ridging also, yellowish discoloration. On musculoskeletal examination, like posture was normal, gait was antalgic. A peripheral joint examination. So on inspection, patient had right hand DIP and PIP. Swelling could be seen and mild, actually not much redness. And on palpation, there was mild tenderness. Similarly, on the left hand index finger also, and painful movement. Other joints were normal. Other joint examination in the peripheral joints were normal. Lower limb on inspection, mainly it was the positive findings in the knee. Patient had a right knee fullness on inspection. Right was little more than the left knee. It was not much warm. However, there was moderate effusion in the right knee and mild in the left. Right knee movements were painful and restricted, while the left knee was terminally restricted and mildly painful. Other examination was normal. Spine examining the spine, patient had normal movements of the cervical spine, thoracic, lumbar spine. However, SI stress on the right side was positive. Anterior sides and sternoclavicular were normal. Schober's was a little reduced, 4 centimeter. Chest expansion was normal. Other system examination was normal. At the end of my history examination, I would like to.
Girija, what other sign in psoriatic arthritis nails would you consider?
So the typical nail changes in psoriasis is pitting, ridging, yellowish discoloration, onycholysis, hyperkeratosis.
There is one more little rarer manifestation. Have you heard of that?
Oil drop.
So what is onychopachydermoperiostitis?
Pachydermoperiostitis is basically a thickening of the nail or even in the joints that we see because of the periostitis, along with periostitis and the new bone formation.
Yeah, so there is complete destruction of the nail. Okay.
Yeah.
And of course, DIP involvement also, periostitis.
Yes.
What is the definition of nail pitting to be able to be to enable you to suspect psoriatic arthritis? There's a particular amount of nail pitting that you see on a nail, because nail pitting is a very otherwise a non-specific sign. A lot of people might have it. So if you get a person with joint pains and if you see and a few nail pits, you might turn around and say, no, this might be psoriatic arthritis in the future. But do you recall the nail pitting?
The more than 5 is significant pits as far as I can recall.
More than 5 pits in the whole nail?
I'm not really sure, so I will read up again.
Anyone else can answer this question? Dipti or Yash?
Sure,
What sir is asking?
No problem, carry on, because we have only 10 minutes.
Yeah, we have less time.
You've done very well, so please don't feel nervous. This whole idea is a teaching exercise. Please carry on.
So I would, at the end of examination, I would like to, the patient could be, is a case of psoriatic arthritis with right sacroiliitis, with peripheral arthritis, with scalp psoriasis, with nail psoriasis, without extra-articular features and without metabolic syndrome. These were the investigations, particularly in this patient. So with mildly raised ESR, CRP, normal blood counts and creatinine, liver enzymes. This is not
anything else, Girija? Any
yes.
other metabolic parameter you would like to do in psoriatic?
Yes, ma'am. I would like to also look at uric acid levels, ma'am.
Yes.
At sugar levels, lipid profile of the patient.
Yes.
And
so often it comes along with hyperuricemia, right?
Yes, ma'am. Yes, ma'am.
Okay.
These were just the X-ray that I came across, and just this is not of this patient, but a representative X-ray. X-ray of pelvis with both the hips. Here we can see this is actually bilateral with irregular SI joint margins bilaterally with some whiskering changes over here. So I just put up just as a part of discussion, ma'am.
So Girija, you will have to take us now that you showed some radiology. Tell me what is characteristic at the sacroiliac joint, what is characteristic at the spine, and what is characteristic if you take X-ray of the hands in psoriatic arthritis.
Yes,
one
sir.
after the other. Yeah.
Yes, sir. Starting with the radiological features on the sacroiliac joints. Sir, in psoriatic and reactive, we typically have asymmetrical involvement of the SI joint, in contrast to ankylosing spondylitis, where we have symmetrical sacroiliitis usually. So they grade it according to the New York grading. Like in psoriasis, typically we see irregularity, erosions of the sacroiliac joint. In the spine, what we see is there are skip lesions compared to AS, where there are more of uniform involvement from below ascending upwards. The psoriasis, mainly how different it is from RA is that psoriasis is erosion with new bone formation, while RA is erosion and juxta-articular osteopenia. And here the syndesmophytes of psoriasis are chunky, non-marginal, and unilateral, whereas in AS, how we look at it is they are thin, marginal, and ultimately fusing up and giving it up as a bamboo spine. Also, I wanted to add on one thing. Whenever these radiological features, eventually we see the X-ray SI changes we see when the disease is chronic after some point of time. However, when we want to look at early involvement in the SI joint, so the best modality is to go for an MRI with stir sequence. In stir, what we see is hyper intensity in the SI joint, which is indicative of marrow edema. So that will show us more
Girija.
of acute.
Okay.
Yes, sir. And
Girija, you demonstrated great knowledge there. I think the X-ray hands are suggestive of primary osteoarthritis. Now prove me wrong.
yes, yes, actually, yes. I just put because of little bit, so I could not get a better X-ray, but I can just, yeah, looks this just the soft tissue swelling here and here, nothing.
So
more.
what happens in psoriatic arthritis in a hand?
In psoriatic hand, yes, ma'am. So in psoriatic hand, we get distal tufting, erosions with like the typical pencil in cup appearance with osteolysis.
That is late.
And yes, late, ma'am. And ultimately, fusion ankylosis of the digits also we see. Periostitis, that something that we see in psoriatic arthritis.
So what is the ray and the row? Have you heard this ray and row pattern?
I was going to. So psoriasis has typically ray involvement, like all like digits, IP joints of one index finger, then not involving the other finger. But however, the row pattern is continuously involvement. Like RA has all MCP, all PIP in a row.
Yeah.
Yes, symmetrical, and this has more of ray involvement.
Deepti and Yash, anything she has missed out, you can add.
About the pencil and cup deformity and also the arthritis mutilans, which can be seen on X-ray, ma'am.
And any other feature?
Acrosteolysis.
Yes.
Yes.
Juxtaarticular new bone formation.
Bony spurs and
She mentioned that?
I think she mentioned about.
Okay.
Girija, any other differential for the spine showing an asymmetrical syndesmophyte, osteophyte, dominantly on the right side in the thoracic area? Gentleman has restricted spine movements, almost giving you the feeling of AS. What would be your other thoughts?
Anders.
Sorry?
Sorry. In the thoracic spine, dish.
Okay.
Yes.
And it stands for? This stands for?
Diffuse idiopathic skeletal hyperostosis. That is basically calcification of the anterior longitudinal ligament, and it gives a flowing candle wax appearance on the lateral X-ray.
Where else do you see calcification on X-rays? Which other illnesses? Suppose you have a lot of disc calcification in the X-ray of this gentleman. What other signs are you looking for?
Wafer-like calcification of the disc, ochronosis, alkaptonuria that we see in. Or,
very good. Yeah, that's what I was looking for. And did I ask anything? Yeah, that's fine. Yeah. Anyway, we have about 3 to 5 minutes. Do you want to touch upon either the differential part that she mentioned? Because I thought that it went clearly on psoriatic arthritis. I think you did well from that point of view, but we would just, as Dr. Kaushik was saying, you would want to encourage your lateral thinking, your thought process, your differential. Otherwise, whatever knowledge you have shown for psoriatic arthritis is very good, and you have presented it very well. But the differential part, even keeping it as one diagnosis, we would want to probe you for, would you consider any other diagnosis saying that the scalp is some severe seborrheic dermatitis and the nail is a fungal infection?
Yes, actually I had thought that way also, and I had kept a differential thinking that it could be scalp and nail is actually could be a fungal, because patient actually complain of a little bit of itching, which is generally rare with psoriasis, and nail could also be just a fungal, and the back pain is different. So that is what also I thought about.
Okay. Any other scalp lesion can you think of along with arthritis? So rashes on scalp and arthritis. Anything else?
Lupus, but it will be a typical DLE kind of.
Yes. So, but you have to keep that in mind if you have a rash on the scalp.
How will you differentiate a psoriatic lesion in a case of spondyloarthropathy? So you're very clear about the fact that this is an inflammatory back pain, and we'll just go down that trend because that's right. That's the correct way to go anyway. But what about keratoderma blennorrhegica? What about the skin lesions that you see in Reiter's syndrome?
Yes,
And
the
would you
skin.
like to show a chronic Reiter's syndrome versus a psoriatic spondyloarthritis?
Yes, readers will typically have these like palmoplantar lesions, which we call keratoderma blenorigica. If it's a male patient, can have certain mucosal lesions on the penile mucosal region, generally painless, which we call circinate balanitis. In female, it could be vulvitis, but nothing. And also, patient can give a prior history of having some unprotected intercourse. Like very less often, they actually describe this history, and actually,
So
yeah,
Reiter's
and
syndrome can be
history.
associated without a history of physical exposure as well. A
Yes,
Reiter's syndrome can also come as a reaction to an infection, a colonic organism.
yes,
And so,
gastrointestinal
yeah,
infections,
so rather than
Shigella,
directing our
Salmonella.
thoughts towards sexual exposure, we could start with just, is there a history of, there's nothing
Yes,
wrong in what you said at all.
yes,
But, you know,
yes,
the rule that we learned under was when you walk on the road, think of the dogs first, not the elephants as a common animals.
yes, so
So you wouldn't want to rule out
gastrointestinal.
GI infection in a city like
Yes,
Bombay. And it might be a
yes,
very insidious loose motion lasting a day, which the patient might forget to tell you.
yes, so
It could also be like Dr. Sunil spoke about the erythema nodosum, and Dr. Bhatt carried that on. And in that differential, you must remember post-streptococcal erythema nodosum and arthritis as well. So the lateral thinking in terms of what are the common causes that you would see in terms of erythema nodosum, and always talk about the common causes first before you come to rarer ones like Behçet's. How common is Behçet's here? So Behçet's comes to mind because it's an enigmatic diagnosis, but the human nature always does that, isn't it? Suppose streptococcal arthritis is where we would start with and then go downwards. Before we talk about, though sarcoid, you're a rheumatologist, so sarcoid and Behçet's is what you must think about, but this is the way to go forward. But you did a great job.
thank
You do you know the criteria for psoriatic arthritis? And
yes, ma'am, it's a classification criteria, Casper classification of psoriatic
okay.
arthritis. So the entry, criteria, or we can say the patient should have either a spine, joint, or enthesis, along with more than 3 of the 5 components. Patient current history of psoriasis is something that carries 2 points, or personal past history or family history carries 1 point. This is one component. The other thing is the typical nail changes of psoriasis that we have spoken about. Then psoriasis, nail changes, dactylitis, RF negativity with other methods and not by latex, and radiologically juxtaarticular new bone formation. More than 3 out of 5 is classification.
How would you manage this case?
So, ma'am, typically in this case, patient has active peripheral arthritis and the spine involvement with mild skin lesions also. So, initially, I would like to start the patient on NSAIDs first, along with a DMARD like methotrexate, which is the time-tested drug in case of peripheral arthritis, and with a moderate dose, like 15 mg per kg with NSAID course, because methotrexate will take some time to start
Not 15
acting.
mg per kg, beta, 0.4 mg per kg. 15 mg per kg.
15 mg.
You're going to treat
No,
it
I meant
weekly.
Yeah.
So methotrexate is not to be taken so lightly. Even in your sleep, this shouldn't happen even accidentally. Okay, beta?
Okay. We have, I think, only a minute before we have to close it, because our next speaker is waiting since 11. So if there is any burning question,
I think one of you just give her a short feedback. Like one of you can just take up, give her a short feedback or some suggestions, and then we'll wind up. Yeah.
Dr. Kaushik.
No, I have given my suggestions. Please carry on. I've asked her to train her thought process that way. And Girija, great job, okay? Please, I hope we didn't make you nervous or anything, because it was a great job.
So I got to learn.
Yeah,
Yeah,
Girija,
so-
I think just 1 or 2 points were that when you say in such an important case, I think you should not pass it off by saying no extra-articular features. You should let the examiner and also your mind know that you have looked for a redness of eye or, a bowel history, because this is an important case. Maybe in any other case where you're dealing, you can just say no extra-articular feature, but here it is a very important finding. So the history should also elaborate on what you have asked for.
Yeah.
And otherwise, fantastic job. And you presented well, you were prepared well. Yeah.
Yeah. So good job, Girija, all in all, as both have pointed out. Little more lateral thinking, because he's a 48-year-old man and low back pain deserves all its, differentials.
Yes.
So you have to bring that out in the history. Overall,
Thank you,
nice.
Dr. Girija, for a good presentation. Thank you, Dr. Kaushik, Dr. Varsha, Dr. Sunil. For
Oh,
being
thank you
very,
for the
Thank you, ma'am.
Excuse me, ma'am.
dynamic faculty.
Excuse me, ma'am.
Yeah.
I had a question actually, ma'am, regarding the number of pits that are significant in psoriatic arthritis in the nails. So as Dr. Bhojani sir had asked you which area of the nail would be involved, like specifically. So sir, is it the nail plate or the perionychium or what, ma'am? Hello.
I think we can just mail Dr. Bhojani. Dr.
Sure.
Bhojani, you're there?
Yeah, I'm sorry. I had just I was drinking water. I'm sorry. Dr. Yash, the 25 nail pits in a square centimeter on the nail plate, and 5 pits is fairly common on a nail plate that Dr. Girija spoke about, and you will find them very commonly in a lot of patients who have got no connection with psoriatic arthritis.
Right.
So it's a concentrated area in which you find a lot of nail pits. And there are some beautiful photographs. I used to have, if you share your email ID, I'll give it to you, because I was part of the first rheumatology slide compendium with Dr. V.R. Joshi when we made it. And we've got a fantastic photograph in that on nail pits. And I'll kind of mail it to you.
Sure.
So yes, there are some papers which say that total taken hands together, more than 20 nail pits are suggestive, and actually more than 60 is quite definitive of.
Confirmatory,
But
yeah.
yes,
Okay.
it's confirmatory. This is just for knowledge point of view.
Yes.
There are papers to say, put it that way. Okay, I think Dr. Kavita, you take over.
Yeah, okay, I take pleasure. Thank you, everyone. I take great pleasure to invite Dr. Avinash Jain. Your video is on. Maybe they can see you. Hello, Dr. Avinash.
Oh, yeah. I think
Yeah.
I'm visible. Yeah.
Yes, yes. So hi,
Yes,
good
yes.
afternoon. Thank you for joining us today. So I think most of you already know him, but still I would like to introduce him. He's a very dynamic young faculty from SMS Medical College and Hospital, Jaipur. He's an alumni of SGPGI Lucknow. And he's a very esteemed IRA EC member, IRA webmaster, a quiz master, as all of you know him. Multiple awards to him, multiple papers. He's collaborating a lot of studies on lupus, sarcoid, Takayasus. So he's one of the few rheumatologists, or maybe the only one who's doing qualitative research and has a very good liaison with ICMR. And we had the good fortune of meeting him at Bharati Vidyapeeth when he arrived at Pune about, I think, 3-4 months back, 5-6 months back.
Yes.
So we had a very good interaction. So today he's going to talk about qualitative research, and we're looking forward to your talk. Over to you, Dr. Avinash.
Thank you, ma'am, for being so liberal. मेरा अगला हफ्ता तो पूरा quality अच्छा हो गया है after hearing, for the generous comments. Thank you for the opportunity, including the esteemed teachers. And I think it was worth the wait, joining at 11 a.m. Very well presented. I really like the slides. And hopefully I'll ask some students also to, be part of this teaching program. So the topic that I'm going to speak on is basically, so this was part of my training when I had gone to University of Birmingham. I was probably, sahi samay pe sahi jagah tha. That funding came, the project came, and I landed up doing this. And I'll tell you the story as, we discuss some concepts of qualitative research. Again, it's a very big field. I'm more familiar with the methods that I have used, and we have 2 papers now. And we are planning to do another study, but as of now, it's just 2 papers that we have published in the last 2 years or so. And just to give some funny title, is it all a numbers game? Because at the end of the day, it's all about, numbers and Mahatma Gandhi notes and all. So I would start with this quote, a very good book by Greenhawk, Tisha Greenhawk. A work-weary colleague advised me, find something to measure and keep on measuring it until you have got a box full of data. Then stop measuring and start writing up. But what should I measure? I asked. That, he said cynically, doesn't much matter, but just measure, talking about numbers. So this is the outline for today's talk for next 20 minutes or so. Introduction, what are the types of qualitative research? With my study, I will try to explain the ingredients of qualitative research, the methodologies, how do we conduct it, how do we analyze it, the strengths, and then we will wind up the differences between qualitative and quantitative research. So if your phone is on and you can scan the code, I would be interested in knowing how many of us have heard about qualitative research. Yes, no, maybe, or we do it day in and day out, assessing quality of life in lots of patients. To be honest, I had never heard about it, and you will learn when this study and this project and this funding came along. We just sounded like a fool, So let's begin with another very interesting example. A small child runs from the garden and says excitedly, "Mummy, the leaves are falling off the trees." Mother tells him, "Tell me more." He says, 5 leaves fell in the first hour, 10 leaves fell in the second. And this child went on to become a quantitative researcher. Another child, again the same question, but now he tells, the leaves are big and flat, mostly yellow or red, and they seem to be falling off some trees but not others. And this child goes on to become a qualitative researcher. So this is what I'm trying to sum up by this example, that's what actually the difference is. Qualitative research is basically studying a patient or a number of things in their natural setting. For example, patients with diabetes and their quality of life assessment, if we do, does not mean it's a qualitative research, because again, there we are calculating some scores, it's quantitative research. But if you want to understand their life perspective, this is something what is called as qualitative research. Basically, studying things in their natural setting, trying to make sense or interpret the phenomena, the things as they unfold. You're trying to understand their perspectives, understand their experience or culture. Basically, a holistic perspective which preserves the complexities of human behavior, or something which is often used whenever we are trying to synthesize or make a quality of life questionnaire. How do you think, a quality of life questionnaire can be made? Unless and until you sit with the patients, talk to them, we cannot frame these questions. So that is how it all starts, right? The purpose is basically to explore their perspective, understand the culture, to make sense of process in their natural setting, and to make sense of phenomena within the context of where it is enacted. This is what qualitative research is all about. Now I will, with the help of the study that we had conducted, I would take you through how the sampling is done, how the data is selected, what are the various methods, and how do we really analyze it? Something very interesting. The analysis part was really an eye-opener. To compare, let's start with an example. In a quantitative study, we always start with a hypothesis. Does increased smoking lead to rheumatoid arthritis? What we will do, we'll make a group, an experimental group, a control group. We will see patients who are exposed and who are not exposed and calculate various ratios, and then come up with an answer. As against another question, research question, why can people not give up smoking? Now this is where we'll have to sit with the patient and do something called as purposive sampling. I'll come back to this. What is the difference between random sampling and purposive sampling, something which is at the heart of qualitative research. And there are various other methods too that have been described, convenient, theoretical. So purposive sampling is what happens is, say for example, in this question, why can people not give up smoking? My aim would be to pick up patients who have rheumatoid arthritis and who are smokers, obviously, otherwise the study will not make sense. But I'll also make sure that I have people from various strata of, lower socioeconomic status, maybe higher socioeconomic status, those who smoke different kind of smokes, the tobacco, and then try to understand their behavior. Because if I have, so basically I have decided my sample, what kind of patients I want, unlike quantitative research, where it's all either randomized or we take some consecutive samples. So this is what purposive sampling is. And once we have decided our set of patients, these kind of patients we will take, we do some interviews. There are various methods by which the data can be captured. We document them, we analyze them, and then we come up with the hypothesis or an idea, something exactly opposite of quantitative research. So this is, when the study and the funding and the project came to us when I was at SGPGI, they told me that, they want to understand the effect of rheumatoid arthritis on employment as well as on their life amongst people of South Asian origin. So my mentor, Dr. Kanta Kumar, works on ethnicity, and she's based out of University of Birmingham, which have lots of diverse ethnic population, and she focuses mainly on South Asia. She does have papers where she has tried to understand something similar in people who are employed or working there but living in UK. But they wanted to understand, is it something same which happens across the continent, across the globe? And the funding came from the India Institute, which is based at University of Birmingham. So initially I was in two minds, never heard of it. I really don't know whether, what sense will it make? Will I really be doing it in future? What extra will I learn? But then ultimately I decided, I think it's a good opportunity knocking at the door. And with the funding available, I said yes. And the first question that obviously comes to our mind, with no background knowledge of qualitative research, is when she asked me, when I asked her actually, the target participants, number of patients that you would need. And we were like, so we have more than 10,000 that red colored files at SGPGI for rheumatoid arthritis. And we were like, हाँ हम तो दे देंगे, कोई दिक्कत नहीं है, कितने पेशेंट चाहिए, 1000, 2000, कितना लेना होता है. And then she literally burst into laughter, and you would be surprised that something which is really unique about qualitative research, a concept called as saturation, which I'll introduce you as I'll start, with my project, is the sample size invariably varies from 10 to 50. और हम लोग की आदत होती है ना, हाँ हो जाएगा, 100 हो जाएंगे. And I was, so happy. अच्छा, सिर्फ 20 patient. I was like, this is a very a cakewalk. We can finish off in 2 days, this study. But then gradually, I realized as I learned, I went for training for a month first before the study could be initiated. I realized something is similar. You need to have your aim. Like, for example, the aim here was exploring the effect of rheumatoid arthritis on employment. Methods, which means the type of qualitative research you want to do, the kind of sample that you want, and how you want that sample. And then we will come to results and discussion. So types of qualitative research, just let me take you through this. You can park this slide somewhere at the corner of your brain. We will come back to it. We learned a bit about sampling. Now, these are the approaches. There's something called as grounded theory, phenomenology, ethnography, and there is something when you have collected your data, how you're going to analyze it. Content analysis, thematic analysis. Grounded theory is something which is very commonly used, where what happens is, as the data is being generated, you need to analyze it. This analysis is very important. There are some codes which will be generated, which will help us in generating more data. So these are the 2 papers which we had published out of the 6 months of fellowship: work productivity loss among rheumatoid arthritis patients, a qualitative study, and delay in seeking medical help in patients with rheumatoid arthritis. And one thing which I learned thankfully the studies got published. Otherwise, my quality of life might have got a little hampered having received funding. So what I realized is, the kind of group that was made. It is very important in a qualitative study that you get perspective of people from different backgrounds. So we had an epidemiologist, we had a few rheumatologists, two from India, one from US. We had an occupational therapist, another rheumatologist from UK. So that was the kind of team that we had made. And I'll tell you why this was important, because of a concept called as triangulation. I'll come back to that. So we decided we will be doing a thematic analysis. And this is how, I collected my data by doing interviews. So there are various methods by which you can collect the data. There are interview-based methods, which could be individual or focused or group method. You can simply observe. You're sitting in the room, patients are talking, you're just observing their behavior and recording and taking notes. There can be written narratives or diaries, which means, the patients who write their diaries, you collect their notes, you analyze them, and you make sense out of it. Basically, you are understanding their perspectives in a natural setting. That is what, qualitative research is, and even hospital notes. So interview could be one-to-one. It could be basically face-to-face, even telephonic. Sometimes we do it telephonic. People have even started doing it through Facebook messengers, Instagram messaging, and trying to analyze people's behavior, because that is, how tech savvy these qualitative researchers have become. And while doing this interview, it could be a semi-structured or an in-depth interview, which means the method that I had used was semi-structured, which means we have to prepare a topic guide using some patient partners. So what happens is, say I was trying to study the impact of the disease on work efficiency. So what I would do is, first and foremost, I would try to identify 2 or 3 patient partners, who will help me in deciding what questions should go into my interview. And note, these questions, this would be just simple 3 or 4 headings, So I sat with 2 from India and 1 from UK, a teacher, a businesswoman, and another was a shopkeeper. They told me, you should ask them about these things. This is important. You should ask about these. And that's how I prepared a sort of topic guide, which would help me in starting my interview. And this topic guide keeps on expanding as we take interviews. I'll tell you more about it. And when we say in-depth is, more like sitting with them, tell me something more, and trying to extract, understand their perspectives, depending on the question that you want to get from them. Similarly, there can be focus groups, which mean a group of 4 to 12 people can sit together, and with the help of moderator and the researcher, not only you will be asking them question one-on-one, but you will also facilitate that these patients talk to each other, and then you understand their behavior, their pattern, how they're trying to live with that particular disease or chronic disease. So this is the method that I had used: individual interviews, focused, basically one-on-one. But as I mentioned, it was very important that you need to first figure out, have a semi-structured methodology by which you prepare some questions, and that's how you start your interview. The concept of topic guide, patient partners. And remember, I had used the term purposive sampling. So once my topic guide is ready, I need to ensure that I purposefully select patients from different backgrounds. So if you look at my table here, I made sure that they were both male and female. There was no, gender bias where I was just taking males, because the perspectives will differ. Even if you look at level of education, I had to ensure that after every patient, once I have started with patient 1, I would make notes. I'll see, postgraduates, graduates, primary, even illiterate, secondary school, because they all will have a different perspective. But one thing which was important was all of them were employed. And even if you look at type of employment, they were coming from different categories. Some were teachers, some were even doctors, housemaid, police constable, firefighter, construction worker, homeopathy practitioner. One was a teacher, professor, another was a driver, farmer. This ensured that this is what is called as purposive sampling. This ensured that I had variety of patients to interview. So what happens? How do I decide the number? What to do after the interview? So for once I have interviewed patient number 1, what happens is, so I would do an audio recording. It is generally advisable that because these interviews could last for 45 minutes to 60 minutes. The entire interview is audio recorded. At the same time, I have to take some notes, trying to pinpoint or pick up some really important stuff that they might be saying. Once the audio recording is being done, generally it is sent to a third person so that a bias is not introduced, who would translate or it was recorded in Hindi. And since the funding was from UK, a UK company, a UK person who was well versed with Hindi and English did the translation and then transcribed it. And once I had received the transcript, I had to analyze it. Now, this is where it differs from quantitative research. You cannot wait till the end of recruitment, have all the patients on board, and then do your analysis. Once I have interviewed patient number 1, I will have a transcript, and I'll show you this is how the transcript looks like. I have started analyzing my first patient's transcript, something called as open and axial coding. What I do is I'll go through each and every notes twice, thrice. For example, first 6 months, I could not make out anything at all. My husband asked me to get myself checked. I had a lot of swelling and stiffness. Then I started feeling sleepy during the day. At night, the pain in the joints would increase. I could not sleep at all. So, I'm trying to make notes here. This is called as open coding. As many points I can pick up from this, I'll have to write it down here. There is no knowledge initially. She could not understand the signs and symptoms, whether it's a disease. There was fatigue. Then during the interview, patient would tell you various reasons, why this disease came. There would be points on denial and so on and so forth. So you realize I'm trying to code. The reason why we are doing open coding is we have to pick up themes from this, what patients are trying to say. And as now when I have to move to patient number 2, what I'll do is there are some important points which were raised by patient 1, which were not there in my topic guide. Now I'll add these questions in the topic guide, which means if I had a set of 5 or 6 questions, now I have a set of 9 or 10 questions, which I will make sure that I'll ask my patient number 2. So I will revisit the topic guide. I'll add questions. This is called as progressive focusing, which means something that you cannot do in a quantitative research. You have made your case report form. You have identified that this is what you're going to do. You cannot change midway. But here, the concept of progressive focusing is there, which means you are changing your research question as you are doing the research. This is called as progressive focusing, largely iterative thinking, iterative analysis. As you go along, your research methods, your questions, your topic guide keeps on changing. And this process will keep on going, patient, translation, coding, axial coding, which means when I'm doing an open coding, there will be lots of repetitions. So I'll try to club some of these into subcategories. Say, for example, fatigue, weakness, tired at the end of the day. They will all come under one particular subcategory, which is called as axial coding. But all of these questions will keep on going, keep on adding to the topic guide till I end up at a point where no new themes, no new codes are emerging, which means, and that generally happens at the end of 15 or 20 patients. So what does that mean? Saturation means there is nothing new which is coming out of interview now. All the perspectives more or less have been addressed. So you realize that though the number of patients were only 20, it took me nearly 4 months to complete recruiting these 20 patients. You cannot recruit more than 1 patient a week because, in fact, in 2 weeks sometimes, because it has to get translated, it has to get transcribed. I need to update my topic guide. And then with a fresh mind, again, I have to sit for another 45 to 60 minutes. It's very important that, you take you make the patient comfortable so that he or she tells you each and everything, and a lot of these patients would cry during those interviews, and you have to handle these situations because उनके लिए तो ऐसा था कि इतना टाइम, मतलब you are sitting with a doctor for an hour. This is what qualitative research is actually all about. So once my data is complete, once all the codes, so I'll make a map, various codes, सारे मैंने अपने डायरी में बना रखे हैं. I'll make categories, and then what I have to do is all these categories have to be clubbed into 3 or 4 or maybe 5 themes. Codes followed by categories followed by themes, and these are the 5 themes which came out after a work of 5 months. I could club all of these codes, all of these categories into 5 themes: journey of developing rheumatoid arthritis, and impact on self and family, where the patients describe their general life, then their experiences at work, what changed, what adaptations that they did, what support they got at workplace and from the family, from the social media, and the recommendations. These interviews would often end up with recommendations, something very important. And to make sure that so this is something which people would always ask, people who are doing quantitative research, कि इसमें तो bias होगा, because it's just my mind thinking, my analysis. So what is important is at least 2 to 3 transcripts should go to each author who is on board. They too should do their own codings, or axial coding, open coding, and then you have to sit with them and see how many things are matching. Some of the codes would be very much similar, that will be absorbed. Some of the codes, some of the places where you would disargue and you would say that, no, it doesn't imply that, you have to let that go. So at least 2 researchers should do it. In my case, all the 4 or 5 or 6 researchers did 2 to 3 transcripts. And once these themes and categories are ready, you actually also have to go back to the patient and tell them, these are the results which came up. Do you agree with it? Does it really resonate with you? People talking about workplace adaptation, unhone aisa kiya. You have to give them. And ideally, 1 or 2 transcripts you should sit with those transcripts with the patient partners, so that they understand what has really happened. And how do now this is something very interesting. Themes bana li, ab themes to kuch bhi bana sakte hain. How will you support? Like, you don't have the numbers here. So this is interesting. This is how we support. So we have one entire table which will consist of 50 to 70 quotes for each theme. And we have to write these quotes like this. Say, for example, a 63 male advocate. I feel much more tired when you compare to before. I felt like I was slowing down. Another male doing government job will tell me, the main reason I come here is because I want to keep the disease in control. For that, I'll do whatever is necessary. Something really good, something that tells us about adapting. 41 male security, he'll tell us, I have to go to work for the sake of children. Even if there is pain, I feel helpless. So another perspective of a patient, why he wants to remain in work. So these are the quotes which we have to publish while trying to consolidate or tell how these themes have emerged and what are the quotes which refute or tell us. And one thing which is very important is you cannot just have quotes which are positive and completely support your themes. There can be quotes which are against the conclusions that you have drawn, which is very important because that will tell us that there was no bias being introduced. So what we realized at the end of the study is patients who had high productivity had very good support from family, from media, were self-motivated. They were at a job which would allow them to, delegate their work. There was an element of hierarchy being involved there. If they were the bosses, it was much easier for them. For the farmers or maybe for the laborers, it was much more difficult. And there was difference in level of tolerance, positive thinking towards work. So this was resulting in a higher productivity. Obviously, we have not quantified it, but this is how we analyze it. And patients who had private job, they had much more pressures. They could not flex, the timing of the job was not flexible. All these were resulting in, poor productivity. And there are methods by which you can even measure this, which is basically quantitative research, where something called as presentism, absenteeism, where you can calculate the efficiency of patients who have this disease. Some more examples, I was really thrilled that, a title of a paper can be like this. It just made me feel so desolate. Patients' narratives of weight gain following laparoscopic insertion of a gastric band. And what they did, again, you will notice a purposive sample of 10 patients was taken. They did that coding, they did the thematic analysis, and 3 major themes emerged: living with side effects, regret, and lack of support. And they reflected that difficulties these participants experienced and provided new insights on why weight loss is not sustained after 2 years following surgery. Now, this is something which is probably not easy to capture in quantitative research. Having understood their perspectives, it would be very interesting for a surgeon to bring these into post-op care. How to, really help them 2 years following surgery so that they don't gain weight. So coming back to various types, grounded theory is something I talked about. The data is being generated and you analyze as these being is generated. Phenomenology is nothing but studying a particular phenomena which the patient is experiencing. Again, most commonly, these are observational. You sit, you listen to them as they are experiencing that phenomena. Say, for example, a patient may have burn and experiencing pain, and you're just sitting and analyzing them. There is another thing called as ethnography, another type of qualitative research where you are a passive observer. You're sitting in the room full of, say, patients of a particular type, and you just seeing their behavior, understanding their behavior. And once you have collected your data, you do a analysis which are of various types. This I've already told: semi-structured interview, in-depth interview. This is how you do the analysis. Something called as thematic analysis, which we did. You become familiar with the data, you generate codes, you look for themes, you try to club all these codes into these themes, you keep on revising your themes, and finally you come up with 3 or 5 final themes. And you produce your report substantiated by quotes from these patients. Some people would do like this. They will make coding in this fashion, make a subcategory here, and then make a larger theme here, which could fall under all these categories. There is another method of analysis which have not been trained, but it's called as discourse analysis, detailed study of words and phrases and formats used in particular social contexts. So I'll just wind up with, what is the difference between qualitative and quantitative research. Qualitative is all about understanding. This is all about numbers. A holistic approach, a term called as naturalism being used. Subjective, what is X instead of how many X? It's more of an exploration. The sampling is generally purposive. Here it is random. Here the hypothesis is generated, whereas in quantitative research, it's being tested. Now, the analysis could be anything even from poem. People have analyzed poem of patients who write poems when they are ill. It could be pictures or images that they are drawing. It could be their diaries, or it could be interviews. Basically, you just want to understand the ideas and their perspectives in a structured, semi-structured, or a non-structured way. And mind you, there are softwares. It's just not that the quantitative studies will have SPSS. There are softwares for analyzing a large data set or for clubbing those codes, something called as NVivo. I have not been trained in that. But the best method is VLDRT, very large dining room table. You sit with your printout and a pen and do the coding like I had done and make notes. This is what is qualitative research is all about. The strength is it gains an insider's view of the field. It can play an important role of suggesting possible relationships, causes, effects, and dynamic processes. And then it feeds into a quantitative study. Validity or reliability could be an issue and a major criticism. And if you have not included, if your purposive sampling is not good, the generalization might become very difficult. It is very time consuming, and the researcher has to be there all the time conducting those interviews. So I'll just wind up with a few more examples. Quantitative research is how many parents would consult their GP when their child has a mild temperature. Whereas qualitative would be, why do parents worry so much about their child's temperature? What proportion of smokers have tried to give up? What stops people giving up smoking? This becomes a qualitative question, and this becomes a quantitative question. And I have used this example a lot of times. Looking at this shoe, how many of you see it as blue and how many of you are seeing this as pink is something what qualitative research is. Understanding the perspective, but in order to avoid bias, it's important that you do triangulation. So qualitative research is basically immersing yourself in natural setting, concentrate on their point of view, collect and analyze. This should go together. Purposive sampling is important. Thematic analysis is most commonly used. And we understood some terms like iterative approach, progressive focusing, triangulation, which means that a particular transcript, a particular set of transcripts should be analyzed by different researchers in the team. And these are supported by quotes, what patients tell. So this is a number game, and this is what a quality study looks like. Thank you.
Thank you very much, Dr. Avinash. It was really fantastic. So I had just one or two questions before I open it to others also to ask. One is when we publish when you publish these articles, so when the standard, you have a lot of some references that follow the article, etc. So in your qualitative research, when you publish it, do you also back it up with some studies that have been done, or the format of?
So yeah, I think, ma'am, that's a good question. So generally, so for example, for this study, living with RA, looking at quality of life, there were a lot of papers which were helpful. But something interesting about qualitative studies, you can start afresh, where nothing has been done, but you are trying to delve into this particular area of interest. So there could be studies which could back you up, or there could be no studies and a totally new area which you are trying to assess. Something, for example, if you don't have a quality of life assessment for a particular disease, say, for example, ANCA vasculitis, and today you want to decide, let us make some questionnaire specifically to say GPA or something like that. So that is where we will start qualitative studies. Totally de novo, pehle nahi hua hai. Obviously, we will review literature, but it's not necessary that you may find such kind of studies. And if there are, you have to back it up with those.
Other thing was you have done DM from a institute which has so much of research. So, but you feel if you want to do qualitative research, your training which you did at Birmingham, is it essential? Or if some, like my postgraduate student wants to do something right now, they can start off, or the training is essential?
Training is essential, ma'am. So this also I realized when we were writing the methods in the paper. In the paper, the reviewer and the journal would want someone who has been trained to do this qualitative study. And that goes into the methods. It started with, AJ was trained for these methods by so and so and so and so. Because, I realized it was not easy even after that 1 month of training. I felt probably I need more time to understand, because I just understood a part of that qualitative research, which was thematic analysis, some concepts of grounded query. So some training is definitely required by a person who does work on qualitative research, because that will at least make sure that the analysis part is proper. Because ma'am, yahan numbers to hai nahi, it's all perspectives. If you have not made your codes, your categories properly, you may not get a meaningful conclusion out of those studies. Sometimes it appears very obvious, but still you have to have that perspective and that understanding for doing. So generally what they would do is the journals would ask whether the author has been trained, or there is someone on board who has been trained and was working along with that researcher.
So you have centers in India also which are recognized for this qualitative research training?
Not that I'm aware of. So we did try to introduce this workshop way back in Pondicherry. We only started with concepts of behavioral medicine there. But Dr. Kanta Kumar and others are very much interested if this kind of workshops could become an integral part of IRA, where they can, at least conceptualize this, train them, and do this kind of work.
Yes, more questions are welcome from the audience. Dr. Sunil.
Avinash, very, very interesting perspective. What I wanted to know is that when it comes to the publication, like maybe it's a bias in our own mind, as you rightly said, dominating quantitative. And so how is it in terms of publication acceptance, that when a student or I write it and when it goes, because I can already see that, requiring the requirements of being trained and biases, and there are so many things. So one gets a feeling that the reviewer will bombard you with a lot of questions once you try to publish. So how is the acceptance there? That's what I wanted to understand.
So one thing that is important is identifying the right journal. There are lots of journals who are focusing on qualitative research. Okay. You just need to Google it. You will get at least 15-20 journals who are doing it. BMC is doing it. BMC musculoskeletal journal is doing it. Even Oxford, you will see there are lots of papers which have been, actually we did submit our paper initially to Oxford Rheumatology, but then it went into Rheumatology Advances. They are doing it. There are some papers, even IGRD has some of these publications, but I would agree that if 98 are quantitative, 2 would be qualitative in such journals. But then there are dedicated journals who only work on qualitative papers, and some of them have good impact factor. Sure, so that wouldn't be very difficult, because they have to even identify the reviewers who have been trained. Kyunki har koi nahi review kar pata hai. Like when it went to Advances in Rheumatology, we totally understood from the kind of comments that had come. But when we had sent for another journal, we could figure out, ki kya comment aaye, kyun reject hua, the kind of thing. So that is why journal agar dang se nahi dhoonda, so it becomes all the work is.
Yeah. Anybody else would like to ask? Varsha, Dr. Varsha, Dr. Sandeep. Dr. Shubda is here. Dr. Shubda.
Avinash,
Hi, Dr.
sorry,
Avinash?
no, go ahead.
Yes.
Yeah. So Dr. Avinash, very nice lecture, very nice perspective on, qualitative research. We do it so few times. I just wanted to ask this coding that you were talking about, open and axial coding. So this is at the end of when you've collected your answers?
No. So this happens after every interview. So what happens is, मेरे को 10-15 page की printout आ जाएगा. They have done. A third person should be translating it, transcribing it. And once I have received that 10 or 15 pages interview, I have to sit on that each and every page, read each and every line. And from that every paragraph, I'll pick up some codes, or you can say adjectives, like you saw ki fatigue, tiredness, इस तरह के points मुझे उससे निकालने होंगे. So what happens is, you get more than 100 type of codes. Then you have to categorize them. Ki I can fit, say for example, why did I get RA? Some people will say it is genetic. Some people feel that मैं बहुत काम करता था इसलिए हुआ. Some people say मैं smoking करता था. So it's their perspective on why RA is happening. So that will be, those codes will be categorized into one category. So after every interview, I have to sit down, make codes. The additional reason why I have to do that is, there are some new concepts which come, because you cannot think of everything. You may think that I have seen a lot of RA patients, I have lots of perspective, patient kya sochte honge, but wo kuch na kuch nayi cheez batayenge. And those questionnaires, that kind of feedback will go into your topic guide for the next patient. And this goes on and on till you realize कि अब कुछ नया नहीं आ रहा है. People are talking the same thing. And that's where you stop. Sometimes you stop at 10 patients. कि अब saturation आ गया है, nothing new is. That is why doing coding after every patient will tell you there is nothing new you can come up with. So that's where you stop.
Okay. And then at the end of all this, triangulation, you said.
Yeah,
so
triangulation
kind of validation for
exactly.
your code.
Yeah, because what reviewers and what people with so there are lots of debates which people would do, कि एक ही बंदे का दिमाग है, उसी का पर्सपेक्टिव है, उसको जो कोड निकालना होगा, उसकी जैसी थिंकिंग होगी वो निकाल देगा. But people try to answer that question by this method of triangulation. People from, say, rheumatology, people who are social literacy experts, people who are epidemiologists, and even the patients have sat over those transcripts and agreed over these codes. And these codes, and almost 80-90% of these codes will match. 10% where people would disagree, they are removed, because then you realize that those perspectives are not really matching and not worth getting into final shape. So
you have to mention that when you're publishing.
Yes, exactly. So in the methods, methods is very interesting. It was totally new for me, including how you were trained, who all are on board, how did you interview, did it go to a third person for translation, because there is no bias. Nahi to kya hoga, I'll just pick up my points and transcribe that. How many scripts went to each author? 2 or 3. Ideally, at least 2 people should do it. But they also say, people will say, why not all of those? Because the ultimate understanding सिर्फ एक ही researcher की है, जो बैठा है interview में पूरे time. No one else better can understand those perspectives. So all these things will come into the methodology. And then you will write that coding was done. These are the codes, and you will support them with these codes. Almost 2 or 3 pages codes take up in these publications, 60 or 70 sometimes.
Okay, thank you.
Yeah. Dr. Sandeep,
Yes.
Hi, Sandeep.
Actually, I was very lucky to have a personal interaction with Dr. Kantakumar when I had been to Birmingham. She explains so nicely this qualitative research. I think Dr. Avinash should take forward this effort and small study at least. Okay, so that actually he can guide us. Okay, so it may be a very small study with a small sample size. I think we can start and then take it forward.
It's always a small sample size, but it still takes 6 months.
It is the best way to learn. Unless we do it, we can't learn.
Yeah. No, I agree. But because we have not done anything more, I have not done anything more after coming here, and I realized that. But it's once you do it, you realize it's a different world. It's a different world.
Dr. Shubda?
Yeah, actually, very interesting. We always read about qualitative research, but I don't think we really understand what it is meant. And I think you should train more Indian people, and we should carry this forward. I think that will be very good.
I think you should train us first. Then we'll.
अभी वो level नहीं आया. I need to do more studies myself. I need to understand those nuances. But I think the University of Birmingham and people there would be really happy. And I can discuss with them that people are interested, and at least we can make a start in IRA, the workshop kind of thing, so that we can identify those people who are really interested. Because India में ऐसे publications I think बहुत कम है. मतलब and all these things have already been published there 10 years ago. ये लोग तो 10-15 साल से कर रहे हैं, living with this disease, living with RA. And I think it's really good for patients if you give them to read these papers. They really correlate well. कि ये तो सबके साथ हो रहा है, something like support group kind of concept.
Avinash, does it also mean that when he says the researcher and his presence and the time, that this cannot be done as a multi-center study at all, a similar topic or same topic being taken by a group of researchers and then doing it, it will be outright rejected, or does it still have some, I mean, we can still
I think
do
that's a very good method that you have suggested. It is more like, I think, a mixed method where, now the problem is, each center, you still have to reach that saturation. Right? So for example, living with RA, what I'll be doing is I'll be focusing on North Indians. You might be focusing on Western India. So I think it's a very good concept, but I really don't know how we can really amalgamate and bring them together, because it would be such a volume of data कि एक साथ किस तरह से उसको analyze करेंगे, something I'm not confident in answering. But I think it's a very good thought, because some themes will be similar, maybe, we can club few themes which are similar for all the patients, irrespective of from where they're coming. And then we can have a theme where, where people differed. So I think that's a very good thought. I think I can discuss this with my mentor and come back. कि इस तरह का भी कुछ कर सकते हैं क्या?
Sure, thank you.
Yeah.
Can we take help of Chat GPT to analyze data?
हाँ, क्यों नहीं? Why not? Let's see what they come up with. शायद Chat GPT का ट्रेनिंग हुआ है कि नहीं पता करना पड़ेगा.
Yeah, but that can be an attractive solution.
Yeah. So they do have a software, Sandeep. They have a software, Atlas software, NVivo software, where you throw all these codes there. They will rearrange and club those codes into categories accordingly. So वो already है. They will number those codes so that you can use those numbers. So the software is already there, and particularly when the data is very huge. For example, the PhD students there who would work on qualitative research, उनके लिए they say that at least 30 to 50 patients they have to take. इतना ज़्यादा in depth, इतना ज़्यादा और analysis that they need to do. That is where they would use those softwares. जबकि number सिर्फ 30 to 50 है, but इतने codes generate हो जाते हैं कि पता ही नहीं चलता है कि कुछ छूट गया क्या repetitive है.
I think that's the problem we have to work around so that it will be to meaningful conclusion.
Dr. Kaushik, would you like to ask something?
Nothing, thank you. I was so overawed with the entire presentation that I was just kind of imbibing everything. There were really no questions. So thank you, Avinash. That was a fantastic perspective.
Thank you, sir.
Students,
thank you
any
so much.
questions from the students? Okay, so thank you so much, Dr. Avinash. We really had a great time. All the best to you. See you soon
Thank
in
you.
Jaipur.
Yeah, thank you, ma'am. Yeah.
Bye. Thank you, everyone, for joining.
Thank you, everyone.
Thank you so much.
Bye. Good day to all of you.
Bye. Thank you. Bye.
Thank you, Agnes.